Hello everyone, my name is Radwa. For this week, I did my topic on pancreatitis. So let's get started. For the disease process, and medically, the pancreas lies transversely in the upper left quadrant area of the abdomen. It is located just behind the stomach and it is at the same level as the breastbone. This organ plays a very critical role in regulating the body's blood sugar level via the production of insulin and glycogen. The pancreas also has an important function as it is the source for producing and secreting digestive fluids, as well as the digestive enzymes. In healthy individuals, those enzymes do not become active until they reach the small intestine. As the pancreas becomes inflamed, the pancreatic enzymes are at a greater risk of becoming activated much sooner within the pancreas as opposed to the small intestine. As a result, self-digestion occurs. This disease process is known as pancreatitis. Pancreatitis can also occur due to the several factors and result in varied symptoms. It is one of the few diseases when even in mild cases an individual will require hospitalization. Mild or acute pancreatitis signs and symptoms can be portrayed as an abrupt attack that causes pancreatic inflammation, often associated with sudden, severe pain in the upper abdominal area. The pancreatitis attack is characterized as a serious disease and usually lead to patients being admitted to intensive care units to be closely monitored, as this disease can lead to a number of serious complications. Some of the complications are bleeding, infections, hyperglycemia, and permanent tissue damage. For the pathophysiology, a few of the main functions of the pancreas are the release of insulin and glycogen hormones. Insulin and glycogen are then released into one's bloodstream. The purpose of these two hormones are to help one's body regulate its glucose level. Glucose is extracted from the food in order to be used for energy production. Another main function of the pancreas is that it's extremely important in the secretions of the digestive enzymes. These digestive enzymes travel through the pancreatic duct and are mixed in with bile to help with the food digesting. In healthy pancreas, the digestive enzymes are produced and secreted as sigmoids into the duodenum, where they become active. As the enzymes travel through the pancreatic duct, the peptide group blocks the enzyme's catalytic domain in activating the enzymes. Once the enzymes reach the small intestine, entropeptidase is then secreted by the interstitial brush border cells. As a result, the peptide group is removed and the catalytic domain of trypsin is freed, allowing it to activate the digestive enzymes present within the small intestine. The system is crucial as it helps protect the secretory duct system, as well as the pancreas from potentially being harmed by the enzymes during the synthesis and secretions. When the pancreas becomes inflamed, both the pancreas as well as the pancreatic duct system are both degraded by the organ's very own secreted enzymes to the breakdown of this protective process. As a result, the pancreatic endocrine as well as the exocrine functions will suffer accordingly. For risk factors, pancreatitis can either be acute or chronic. Acute pancreatitis can become a life-threatening attack that occurs suddenly with no prior predisposition in a previously healthy person. Whereas the chronic form of pancreatitis is progressive with recurrent attacks. There are many factors that can lead to acute pancreatitis. The most common cause of pancreatitis is seen in inpatient hospital settings, include metabolic disorders such as hereditary pancreatitis and structural abnormalities, including pancreas dysfunction. Other causes include gallstones, penetrating ulcers, heavy alcohol consumptions, abdominal trauma, malignancy, malnutrition, hypercalcemia, or hyperlipidemia. Certain medications such as Lasix, sulfonamide, steroids, and thiazide have been identified as a contributory factor of the pancreatitis. Additionally, mumps, myoclonus pneumonia, and Ascaris have been associated with the development of the pancreatitis. Other causes include pancreas carcinomas, fatty necrosis, or ischemia, followed by BAS, surgery that can potentially block the pancreatic flow, pregnancy, cystic fibrosis, or anorexia. However, chronic pancreatitis is caused by genetic makeup, autoimmune disease, long-term heavy alcohol consumptions, and smoking. For the major signs and symptoms, acute pancreatitis can have varied symptoms among patients. The most common symptoms patients exhibit when seeking medical care for pancreatitis are the sudden, severe onset of intolerable epigastric pain that radiates to their chest area or to the back region. Patients may complain of pain that is accompanied by either nausea, vomiting, or diarrhea. Due to the inflammation, the patient may have a fever, which can precede the onset of the pain. Loss of appetite can result as patients deal with the severity of the pain, which can ultimately lead to signs of malnutrition. Without prompt and proper medical intervention, the patient may become hypovolemic. Hypovolemia may trigger attenuated peripheral perfusion, tachycardia, hypotension, and even shock. One of the complications of pancreatitis is hemodynamic instability that may be accompanied by respiratory distress, as well as peritonitis. Some of the symptoms, including pain, can be exacerbated if an individual consumes fatty food, drinks alcohol, or stands in an upright position. By contrast, the pain level is rather reduced, and one feels some relief when they lay in a fetal position, as this alleviates some of the pressure on the pancreas. This position is the hallmark feature suggesting acute pancreatitis. Most patients suffering from chronic pancreatitis will have many of the symptoms in common with the acute form of the disease, such as the presentation of the epigastric pain. However, the majority of those patients tend to be elderly and may also present with steatorrhea. Depending on the etiology, patients with chronic pancreatitis may also present with diabetes or jaundice. Additionally, individuals with late-stage disease may have developed an addiction as well as tolerance to analgesics. As a result, their personal and professional lives may be in disarray. For diagnostic testing, arriving at a diagnosis of pancreatitis would generally depend on the patient's past medical history, detailed physical assessment of symptoms of possible gallstone, as well as their current presenting complaint of epigastric pain and vomiting. The diagnosis also depends on one's social lifestyle in regards to alcohol consumption, and finally, laboratory findings of elevated level of pancreatic enzymes in the blood. Some laboratory results are time sensitive. If the patient seeks medical care shortly after the onset of their pain, then their amylase level will be elevated by 2 hours. However, if an individual delays care, then amylase level maybe have returned to baseline 36 hours after the onset of the pain. For these patients in particular, the provider will order amylase level to be drawn, but the diagnosis will depend on the elevated level of lipase, as it often remains elevated for at least 2 weeks from the onset of pain. Moreover, lipase level should be closely monitored throughout the course of treatment to help confirm the diagnosis of pancreatitis. If the individual is successfully responding to the treatment and the level of the enzyme is at 3 times its normal level, then this aids in the confirmation of pancreatitis as indicated. In order to rule out other causes, aside from the pancreatic enzymes, other laboratory tests will also include an EPG, blood glucose level, liver function, urea and electrolytes, full blood count, coagulation screening, trig levels, and C-reactive protein. Additionally, the abdominal region should be imaged in order to rule out other bowel obstructions or possible perforation. Imaging studies are used as a definitive confirmation when the providers are arriving at a final diagnosis. However, conducting an ultrasound examination, CT scan, or abdominal X-ray are rather useless in a diagnosis of pancreatitis. However, completing a contrast-enhanced multi-detector computed tomography will often show the provider an enlarged sausage-shaped gland in the patients with pancreatitis. Additionally, a radiograph can also show calcifications of the pancreas. If all the above-mentioned imaging results were found inconclusive or negative, one can perform a secretin test or an MRCP with secretin stimulations. If the results are negative for this test, then an endoscopic ultrasound can be performed. Further examination may be required for individuals with suspected autoimmune pancreatitis. This is the end of my presentation. Thank you so much for listening. I hope you learned a lot. This is one of my favorite topics as I see it so many times in the ICU that I work at. So I hope you learned a lot from my presentation and you enjoyed it. Thank you so much.